agreements in SBIRT, 12 targeted capacity expansion grants for campus SBI across the country, as well as 14 medical professional training grants focused specifically on SBIRT. One of the things that I really want to emphasize that SBIRT, in particular Colorado's leadership around SBIRT, has really truly changed the experience not only for our healthcare systems, the lexicon or language that we use concerning what is substance abuse in healthcare, but most importantly, Colorado and all of your work, and as you will hear today, about the importance that we're actually playing for the lives of our patients and families that are struggling with substance abuse and mental health issues. So with that, I'm pleased to all right, time keep questions here and there. Today's we're going to turn to Melek, who's going to be talking about SBIRT and its impact on health outcomes and healthcare costs across Colorado. We'll then take a short break and then have a presentation by Pamela Balloon-Nelson, who will talk with us about a little bit more in depth about the application and implementation of SBIRT, billing, coding, as well as the patient experience around SBIRT. And then we'll have an opportunity to actually have a panel discussion along with those of you in the audience to find out a little bit more about how we can help shape and move SBIRT going forward. So with that, any questions? Seeing none. So I'm very pleased to introduce Steve Melek to give us our first presentation.
Good afternoon, everyone. Sound check, everyone can hear fine? I've given a fair amount of presentations over my career. This might be the niftiest microphone I've ever had. It is really cool. So, hi, I'm Steve Melek. I'm an actuary. I work for Millliman. Millliman is probably the largest actuarial consulting firm, even though we have a lot of non-actuaries nowadays, in the U.S., if not in the world. It's a pleasure for me to work there, and I've been there for 26 plus years, and I also have the pleasure of specializing in behavioral health care. There aren't many actuaries in the country that want to do that, unfortunately. It's good for business, but it's not really good for healthcare. We need more good behavioral health care actuaries. So I thought when I was first approached on doing this project, I thought, oh yeah, this would be really cool. I'd love to do an actuarial financial analysis. I'm going to give you kind of an executive summary of our results here today. And I was equally delighted when the SIN project came along, and we were asked to be the actuaries in that project. And that's a also very important, cool project that we're doing besides a lot of other things. Actuaries do a lot of financial analysis in healthcare and outcome analyses and stuff like that, and that's what I'm going to talk about today. Briefly, be a little bit of background just to summarize and recap, and then talk about our methodology, our results, some more results, some conclusions, recommendations for further analyses, and there's going to be some caveats in there, because you look at these results and you kind of, as I looked at them and as our internal peer reviewers looked at them, and they kind of went, are these really that good? What's going on here? We should have implemented this nationally years ago if the results are really this good. Well, it's one state, one study, certain practices, and I'll tell you more about that as we go here. So background, and I probably have more words in my presentation here because it's kind of from a report, and I wanted to get you, as I said, a kind of a summary of the report, so there's a lot of words rather than numbers and charts, but you'll see a few of those since I am an actuary. So certainly this is the 2 consecutive 5-year grants, as you know, from SAMHSA, administered by Colorado Department of Human Services, Office of Behavioral Health, and managed and implemented by Peer Assistance Services. And with funding from OBH, we were able to do this study. We had to use the all-payer claim database, and as you probably all know, they don't just hand that out free. There's a cost associated with that, and I know that OBH got a discounted cost on this, but they were able to do that to pay for us and pay for the data, and that's what we did. And our report presents the impact on the total cost of healthcare, and I'll tell you a little bit more about why we did that. We used the all-payer claim database because that was really the source for doing this, and Civic ran that, and I'll tell you the approach we took My first approach would have been when we were first talking about this, oh, okay, so you've got more than 50,000 patients that have been, my term, SBIRTed, and let's just find, give me all those patients' names. We'll find them in the database. We'll look at all their healthcare costs and utilization pre-SBIRT and look at all their data post-SBIRT and do a patient as their own control group sort of thing, because that's about what we have to do here. And the answer was, well, we don't have all those patients' names and dates. Okay, well, then we'll just find them in the claim data. We know which CPT or HCPCS codes get associated with the SBIRT application, and look in the APCD, and we find zero evidence of that because it wasn't paid on a fee-for-service basis. Scrap that idea. What can we do? Well, I can tell you the practices and the dates that they implemented. So what we could do, the best we could do, it's got conditions. The best we could do is attribute patients to those practices, starting with the implementation date, find when they used a service at that practice on or after that implementation date, and then assign that in our technical terms as the index date for that patient, and do it as many as 50,000 times if we can find all these people in the data. So that's why when we went out to the practices and said, give us all your provider identification numbers so we can go into the data, and Civic actually did the attribution in the APCD, sent us this big detailed data file, and then we could have fun with numbers and do what we did. So that's why we did what we did, and if it was total cost of care. And one of the assumptions within this is that once we found a patient, they had a practice that implemented SBIRT, we essentially assumed they got the SBIRT tool administered to them at that index date after it was implemented. We know that's faulty, but we have to make a series of assumptions to do what we did here, and that's what we did. I'll talk more about how we can improve an analysis if we were to do this again. So the goal of the analysis, of course, is to see, was there an impact on healthcare costs and utilization when the SBIRT tool was administered and after? What happened to these patients? Did they get better health care? Did they consume more health care? But did they appear to get healthier because healthcare costs went down? And let's look at it pre, let's look at it post and make some observations and try to make some conclusions. This is not cause and effect. I can tell you that because there's no way to prove it. All we can do is look at what the data tell us, give you some pretty pictures and some charts, and see what it shows, see what's out there. Limitations. So everybody has an index date of when the practice started the SBIRT. Now, maybe a practice said, oh, we started in January of 2015. Oh, that's great, but we really can't do anything for that practice because the claim data barely gets past the first quarter of 2015. We wanted to require a minimum of 3 months pre and 3 months post index date for every patient, so we didn't just have somebody qualified for Medicaid in a couple of months and they're out. So that wouldn't make for a good longitudinal study, so we wanted to get data, a minimum data set on both sides of the index date. So we had to throw out a couple practices because they implemented it too recently. It's not bad, it's just that we didn't have enough data to do it. Really, the early implementers were better because then we can look pre and then we could look post. And what we did for all the patients in this study, we got 24 months minimum of pre-SBIRT date for that patient. Each patient had their own index date, and 21 months post. So we had a pretty good robust period, almost 2 years on each side of the index dates. And the index dates, of course, are all, if I were to show you a chart, you'd see a sort of a scatter diagram where it's clustering around 2012 and 2013 and stuff like that too. But so that's one limitation. Of course, 42 CFR Part 2 limits our ability to look at substance use data. So when it gets to the APCD and they throw it over to 3M, who's being replaced as the vendor for Civic, for the all-payer claim database, but they just, take that data out. So because of, until something happens with this CFR that we cannot actually get that data, we can get everything else. So that's another limitation, is we actually don't have data on substance use services that they would have used pre-SBIRT or post-SBIRT. At a later date, maybe we can actually get that data, but that's one of the limitations of this data. Okay, so enough about methodology, enough about data limitations. Let's start talking about the results. So this is a curve of actuaries tend to look at per member per month cost. That's kind of a standard metric we use. When you get a premium from your health plan, it's usually priced per member per month. Your costs are per member per month. So this is a chart. Remember again, everybody had an index date, which is time t equals 0. That's essentially their visit, where we assumed they got the SBIRT tool administered to them. The negative durations or monthly durations prior to that, the positive durations are post-SBIRT implementation. And of course, we line up all these different implementation dates at t equals 0. So what does the PMPM chart, and this is where all the practices combined, and I'm going to remove one of them in a little bit, but what is this saying? Well, it certainly looks like post-SBIRT per member per month costs are higher than pre-SBIRT costs. So you can jump to the conclusion, oh, SBIRT raises costs. No, not so fast. They are higher, but there's something really important about this, is the rate of change pre-SBIRT and the rate of change in healthcare costs post-SBIRT. Now you see that spike at duration 1, monthly duration 1, because you're getting services, right? When you get SBIRT, you get evaluated, you're in the primary care practice, they're probably lining up more things to do for your health. So what we did in our analyses, while we show all these costs, we actually took the index month where the SBIRT tool is assumed to be administered, and the month before and the month after, because they were both abnormal months. So we pulled all those out of our analyses. So that's just kind of an FYI. We didn't want to distort that, and you can kind of see that spike there, which is going to distort the results. But what this shows is an increasing pattern of healthcare costs per member per month, as low as about $600 pre-SBIRT. And this is commercial, Medicaid, Medicare, any patient that would have been at any of the SBIRT sites that would have seen a doctor. We did not separate them all out. This is, for the most part, a high Medicaid population, and you may or may not have suspected that, but in the practices that contributed, it was mostly Medicaid. But you can see it goes from $600 to about $800 in this 2-year period. You know, it's about $100 a year. That's a decent healthcare trend. And when we look at the trend, again, taking out that 3-month period in the middle to clean up the cost, if you will, look at the difference in the pre-SBIRT annual trend rate versus the post-SBIRT. While the post-SBIRT is higher, costs are coming down during that 21-month period. In the pre-period, they're lower, but look at the ramp-up. They're actually almost at 14% a year increase. So what we've got is an increasing pattern of healthcare costs, not a surprise, pretty rapid rate. SBIRT gets implemented, services get provided, and then what happens following that same group of patients into the future, their healthcare costs are going down. That looks like a pretty nice outcome when you're just talking about trends. And what we did to try to develop, I'm not going to say these are cost saved, because some people say, well, it's hard to measure that as a cost savings, but you maybe call it avoided costs. Maybe they would have spent more on these patients if that 13.8% trend, and this is an assumption we make, if you extrapolate that into the future, you can kind of predict what would have happened if that trend kept on going, if SBIRT had not happened in any of these practices, and if you say SBIRT may have led to healthier patients and reducing healthcare costs in the future, we can compare, again, we had 21 months of actual claims costs for these patients, 21 months. I'm going to show you the results through 24 months. So we just had to project those last 3 months, but to actually get total 24 months post-SBIRT. But what we did was project, and I'm going to show you, we don't have the most recent slide deck in here. Now that's too bad, because I had a nice a nice graph to show you the actual, the projected cost impact. But what essentially it would happen, and I could hold this up, but it wouldn't mean anything to you. What we did was we project, let me go back, we project that pre-period, and just imagine a dotted line going into the future as to what those healthcare costs would look like. And I apologize for the people on the phone who can't see me doing what I'm going to do, but the cost curve would just keep on going like this. So that's what the projected cost would be when you just take an exponential fit of the trend line and project it into the future. And then you look at the actual cost, and the difference between that projected cost and actual cost is what I'm calling avoided costs. So the question here is, did we avoid enough costs to have this actually pay for itself? Or even better, could we have avoided enough costs that we would have gotten a return on investment? We paid for SBIRT and we actually saved money in healthcare costs over time. And again, this is a 2-year period. We don't know, and if we were to do another study at some point, we could look at SBIRT costs beyond the first 2 years. But anyway, that's our difference between actual and avoided costs. So again, I showed you these costs, and I described the results over time. The projected cost compared to the actual cost proved that by the 10th month post-SBIRT, remember I was showing you those two curves that were diverging. One was getting higher and one was actually going down because you've got that minus 2.4. That's actual post-SBIRT results. The pre-SBIRT results, actual results, this is what the data showed for all those attributed patients. By the 10 months post-SBIRT, we were actually saving money in that month on the population. The actual results were actually lower than projected. And if you keep on adding all those savings beyond that point, by the 24 months, we have actually broken even. Now, it's not quite the case it's broken even because I don't know the cost of SBIRT. So we have to actually also have a negative term in there for the cost of administering SBIRT, which we did not have. But net of that, so that's kind of a gross savings. By the 24 months, we would actually have broken even. We saved enough money to pay for all those accumulated costs. Now, I even got better news. One of these sites was the Denver Health Emergency Department. We determined that those patients are a little bit different than patients going to a primary care clinic or a medical center or whatever. And there's different reasons for that. And if you work at Denver Health or have ED experience, you kind of know that. And here's a couple of the reasons we speculated up there that, there are certainly more intense settings, and the ED staff really can't follow those patients along and make sure their self-care is doing well and care management and care coordination and stuff like a primary care practice might do. They might follow those patients and have the care coordinators on the line and all those sorts of things to try to help improve care down the road. So we saw a significantly different healthcare pattern for the emergency department patients. So what we did was remove them. They were, one, significantly different healthcare costs, and two, they had quite a few patients. When we rolled up these 10 out of the 13 practices that we could actually get data from, 3 were so new that we couldn't really get good data from them. But there were a few practices, lots and lots of patients, and then a few with small patients. And what we did not do is show practice name, their results, practice name, their results. We did not want to compare and contrast practices. And I was in pretty close communication with the emergency department folks about, is it okay that we talk about your results being different? I don't want you guys to get mad at us or anything, so we're happy not to show those results, but if you're okay with us showing, because it's pretty dramatic, what if we pull them out? Remember those two trend numbers, before and after SBIRT. When we take out the emergency department, the SBIRT period costs go dramatically down different. And again, if I had those new slides, I would show you the graph of how the non-ED costs go down. So effectively, what this means is, again, stripping out those middle 3 months, pre-SBIRT, excluding emergency department, 8% annual trend. That passes my sniff test. Healthcare costs going up by 8% a year. That passes my sniff test. The emergency department, because the patients are a lot sicker and they're going up even faster, that's why the pre-SBIRT period was closer to 13%. But post-SBIRT, look at that number, almost minus 27%. Like, wow. And again, as my peer reviewer said, why hasn't this been implemented far more reaching places if you get results like that? Well, okay, so now I got to start caveating a little bit. So, but those are the results, and that is a remarkable result. Without the emergency department, in the 9th month, we're avoiding costs, and by the 18th month, we've broken even. So if you said, Steve, if you added in to everything except the emergency department and you followed for 24 months, which is another 6 months from our break even, we probably would have paid for the SBIRT costs themselves and maybe even had a return on investment of all that. So really promising results. So there's some caveats I have to talk about before I ask you what questions you have. Several factors influence healthcare costs. You know, this is not a cause and effect. Look at what SBIRT did. We can't actually say the SBIRT administrative tool did this, but it raises my eyebrows about, wow, the data shows a significant cost difference pre and post for a population that was fairly robust when you added up all the patients that were attributed to these practices. Further analysis would certainly add value because we, again, could only look at patients that were attributed. Some of them probably did not get the SBIRT. A lot of them hopefully did. In the future, I'll talk about some things we could do differently. Patients were attributed to them. We don't know if they actually got screened. So this is our best proxy for a pre-post SBIRT actuarial analysis. We, of course, relied on the attributed patients from CIVIC and the APCD. We have done a lot of analyses for STIM of the APCD, so I generally give it a thumbs up. There are a few still questions that we're working through, and you would expect that when you're getting, it's not quite an all-payer claim database, but it's a significant payer claim database, because a lot of self-funded employers don't have their data in there, so they're payers too. It's just they're self-funded, so that data is not all in there. We couldn't do all the sites. There could be a bias towards if sites implemented earlier and we threw out 3 sites because they implemented in late 2014, 2015. At this point, if we were to run the data again, we'd have more data, probably a year and a half more data than we had when there's been a bit of a history in when we actually got the data, and it was a process to get it all, so it took some time. But anyway, a new advanced study might show different results, and what would certainly help if we could somehow set up a control group, because that's how a lot of evaluators like to do things, is have a control group, study them against the intervention group or experimental group if that's what the SBIRT practices are. And of course, it would be better to actually have names of people and exact implementation dates and then know they got an SBIRT tool. That way we take this broad category of all patients assumed as a proxy for SBIRT and then narrow it down to, now if every patient at those practices after the implementation date got it, we get the exact same result here. I doubt that was actually true, but that's what we had to assume. So here are ways to make the data even better. If we could actually get substance use claims, of course, that would make the data better. It would be possible to do an updated analysis with these same patients, but again, I think in the future, as a more robust and as a more scientific and accurate study for anybody that's going to do an SBIRT study in Colorado, national, anywhere you're going to go. That's what happens with a lot of clinical healthcare changes, is it's a really interesting, cool thing that's being tried. And then 2 years later, it's like, oh, okay, let's look at what happened. And you look at it, and the people that did the work really didn't think about evaluation when they did all the good work. So as an actuary, I would just emphasize that it's like with the SIM work here. When we're thinking about all the evaluation, think about all the data that you want to collect and try to make it available at the beginning of the launch of any sort of a change, because then you've got all the data collected as you're going, and then at the end of the period, you're going to say, we collected all the data, here it is, independently evaluate it and tell us how good we did or didn't do or whatever it is. So that's when I think about, for just to pitch Colorado SIM for a moment, integrated medical, physical health care and primary care practices, and bidirectionally at the community mental health center sites, there have been a lot of pilots done on that type of work in the U.S. in different places. Unfortunately, very, very few of them collected healthcare cost data to look at it to see, well, how effective was it financially? They can say clinical outcomes, but not many people are doing financial outcomes. So that's why I think the SIM project is so cool, because we are absolutely doing a lot of, besides clinical outcomes, customer service outcomes, primary practice outcomes, the quadruple aim, and financial outcomes and healthcare costs. So there's my contact information if you want to, or you think of questions after the fact. I think I've got us on time here. So I am going to open it up to the audience, because we're going to do a little question and answer in between every speaker. And that's not to say you can't ask us a question at the end of everything when we're talking as a panel. But given what I've just presented, I'm glad to answer any questions that people have in the room or over the phone. I know I went fairly quickly to try to keep things rolling here. So yeah, so the question was there no code that triggered, there's the SBIRT right there. It's in the all-payer claim database. Yeah, some sort of a HCPCS code, prevention code, screening code, whatever. And the good news is there are codes set up. The bad news is it wasn't done that way. The claims were not processed that way. And somebody in the room can educate me on how SBIRT was actually completed, but my understanding was there was some sort of a trainer that went to the site that taught how to do the tool, and various different staff members would have done and applied the tool, and it was probably done different in all 10 of the practices, including the emergency department. I don't know if some practices were effectively doing the tool 100% of the time. Others, maybe one of 3 docs was really good at it and the other 2 not. If there was a nurse in the waiting room that did the tool right then and there for every patient before they went in and got their services or whatever. But in the future, if it's a fee-for-service code that gets reimbursed by a payer, Medicaid, Medicare, commercial, whoever, then those codes would be found, and we can find when they got them, the exact date, but pre-post analysis based on those dates. But here in Colorado, at least for us, it wasn't done that way. It was not a fee-for-service claim. So that's why we had to do this attribution approach, because we could not do it that way. But good question. That's what I would have done. If we could have found 50,000 codes with that HCPCS code and the claim data, then we've got our trigger date and the patients right there. No need to ask the practice for anything. So if we're going to do it fee-for-service in the future, then we've got that data paid for. I saw another hand go up, so, or did I answer both questions with, the ER showed that, that's a good question. The full report has that graph in there. Costs kept going up. So that, when I talked about the projected healthcare cost per member per month versus the actual, and they started getting wider and wider apart in the future, even more so, of course, when the emergency department's taken out. Look at emergency department only, and it's almost like a straight line of increasing costs. Those patients are needy and they're sick, and they got the SBIRT, and nothing much changed. It just kept on going up. Might raise the question, at least from a financial aspect, that's not like, the only outcome we want is to reduce healthcare costs. No, SBIRT has a lot of outcomes that others may be talking about. So maybe down the road at some point, using the SBIRT in the emergency department will trigger behavior changes sometime. Maybe you need to get SBIRTed more than once or something, but I don't know. You know, how many times does it take to quit smoking? I think the average number is about 7, something like that. So maybe they need to be told many times to do something different, and it takes them a while to actually do something different. But anyway, good question. The emergency department folks had high cost trends that kept on going. So SBIRT did not change healthcare utilization patterns for that population during this study period. Maybe another study would be useful for that sort of thing. I have a question for you, or anyone that has input. Has any study like this to do a healthcare cost analysis been done outside of Colorado, or is anything underway that somebody's doing elsewhere? Oh, wow. That would be, so there's something I left out. A good future study would also, besides having all the patients with their SBIRT dates, also to cohort them into, was it screening, was it brief intervention, was it a referral to treatment, and did they get the treatment and carry on? Did each of those cohorts actually look different, or was it very similar, or what? But that would be another good cohort analysis. And of course, if we had about 1 million patients, that would of course be nice too. But 50,000 wasn't bad. You know, that's as far as, well, actually, we had more than 50,000 patients because we took everybody that was attributed to those practices. So I think the data shows, I don't know what it's up to now, maybe someone can answer that question, how many patients were screened. But we had a lot of patients in here. I don't have the number at hand as what our N was for all the attributed patients, but it was fairly robust. That these numbers are certainly impressive, and if nothing else, it certainly would beg the question, well, we should keep on trying to do this somehow, some way, because this looks very promising as far as the financial results go. And of course, if you think the clinical results are outstanding too, then as my peer reviewer said, is why isn't this widespread now? Because these results look really good. A couple more minutes for questions, or we'll just take a break. Yes? I can give you the reports, I can give you the slides, I could give you both. The slides are helpful. Sure. So either give me a business card or send me an email there. That's my email address at Millliman, and I would be glad to do that for you. Okay, Aaron's going to send it to the whole group. So if you're somehow with the new slides, yes. In the back, question. We did not do any sort of separation of what the diagnosis would be. We just made sure it was to one of the doctors that was at that practice that we had the national provider identifier. So we looked at, if I was one of the doctors in an SBIRT site, I saw all patients that visited me on or after that implementation date, and if they did visit me for whatever reason they were there for, a broken arm, drunk and disorderly, whatever it would be, that was my patient, that was my index date. We assumed an SBIRT was provided, then did the pre-post analysis for all those patients. So that would be another interesting thing we could do if you thought that the primary diagnosis codes were all going to be as accurate as possible in claim data, which we like to think. Then we could look at the results separate by diagnosis code. If they came in because they were overdosed and did something bad to themselves, and they were, what's the diagnosis code, the medical things that were done, or was it the substance use things that were done, sort of thing. That's up to the docs and how they did that coding. Steve, thank you very much. Again, this is Charlie Smith from SAMHSA, moderating today. Just a couple of notes, particularly for those who are listening online. All of you have received copies electronically of the reports that are being talked about today. We will be sending out the most up-to-date copies of PowerPoint so that you have them. And for those of you here in the audience, you have copies as well.
the documents that Steve and Pam here shortly will be talking about, as well as their additional copies over to the left of the room here. And by the way, help yourselves to light refreshments, and those of you online, feel free to get up, get a cup of coffee, hot tea, and water. You're on your own. So it's my pleasure to introduce Pamela Bilal-Nelson, who is with MGMA Healthcare Consulting Group, and she'll be doing our next presentation. And as Steve had indicated, there's time actually for the presentation, but definitely a little bit of time for us to do the Q&A. Thanks.
Thanks, Charlie, for the introduction, and thanks, Steve, for your presentation, and thanks all of you for being here today. I was hired by Peer Assistance through MGMA Consulting Services to do some qualitative research. So part of my objectives were to provide a summary of interviews with key informants, and these were individuals in the medical practice and payers. So I was looking at an analysis of potential barriers, and these were barriers to coding, these were barriers to workflow, and these were also barriers to reimbursement for the brief intervention and also the screening. Then I made some recommendations to the peer assistants for future interventions to meet the goals of SBIRT utilization. That was phase one. So phase one dealt with the practice level and with the payers. We are now into phase two, which is again qualitative. I am interviewing consumers. So we are looking at the consumers' opinions and views on intervention and brief screening at both the practice level and urgent care and emergency room. Then I am also interviewing employers. So at the employer level, we're taking a look at what is it that they know about SBIRT. Is it part of their plan? Do they even know if it's part of their plan? And what are some of the feelings, observations, and thoughts that they have on SBIRT? So when I look at the barriers and the practice observations, so the methodology, again, was interviewing 6 practices, which are listed at the back of the report there. So my questions in interviewing were centered around awareness and acceptance of SBIRT by the practice team, what their experience was in administering it at the practice level, including the tools they were using, what were the reimbursement issues and how were they billing for SBIRT, if they were billing, and then the patient's perceptions and acceptance of the screening. So there were 3 more implicit barriers to SBIRT that I detected as I interviewed these practices, and these are barriers that I see across the country. First is a lack of care concept across the continuum. Oftentimes it's very difficult for the practices to know what else is happening to this patient outside of this practice. What types of hospitalizations are going on? What other providers are they seeing, especially in mental health and behavioral health areas? Who are they involved with in the community for mental health or behavioral health or for their alcohol? Team workflow awareness. It was often difficult for the team to communicate across the silos to know what are the billing, what's happening at the billing level for SBIRT. Does the billing department communicate with the clinical department to know what is the expectation from the coding, and then also what is the expectation of the contracts with relation to billing SBIRT and what types of tools that need to be used, or who in the practice needs to be administering the screening and or doing the intervention. And then the last, but I think the most important, is the understanding the importance of population health management. And by this I mean looking at the importance of prevention. The ability to be able to aggregate and analyze the patient data to impact the health outcomes of the group of individuals, including the distribution of such outcomes across that population. So what does the practice know about their SBIRT levels within their whole population? How is that shaping the interventions that they are putting forth at the practice level to manage and increase the population health, with specifically looking at SBIRT? So I think one of the most significant and consuming objection that I heard from the practices was the fear of the patient's response when they received a bill. So the practices did not want to, quote, tick off the patients, and they didn't want the patient to get to the point where they felt like they could not answer any question at the office level for fear of it being billed. Now, these were not hypothetical fears on their part. They were real. And I will tell you that although I am still very early in the consumer stage of interviewing, I wish I had a movie camera to videotape the qualitative data when I asked the consumer about their opinion of questioning the questions of SBIRT around alcohol screening and billing the insurance company. They do not like it. They do not believe it's right. In fact, I asked the consumers, I said, so what would you think a consumer would do if it showed up on their bill? Every single one of them. Some of them had some words I wouldn't say here, but every single one of them said they'd be on the phone. I had one consumer who was very astute, and she said, well, does the clinicians tell the patient ahead of time that by answering these questions, it's going to be billed to your insurance company? Now, mind you, no consumer so far has had a problem with these screening questions about alcohol use and brief advice or intervention being asked. Nobody has. So when I asked this person, so if you knew that your clinician or somebody in your physician's practice was going to bill these questions that they're asking you, and they inform you of that, what would you do? And they said, I would refuse to answer the questions. So to date, and again, I haven't finished the total number and all the generation and gender levels yet, but to date, there's some pretty strong feelings from the consumer side about billing what they feel should be questions that physicians, clinicians should automatically be concerned about and ask. Not one denies the importance of these questions for alcohol use. Not one so far. So I think that it's important for us to pay attention to what the consumers feel and think about this issue of SBIRT. So this is real. Another barrier from the staff, and then so one of the questions I've been asking the consumers, who should ask you these screening questions, number one, and then who should be the one to advise or give you an intervention. Of course, they always want the clinician to do everything, right? They would prefer that the clinician be the one to ask them the question and the clinician be the one to give them the advice. But to date, and again, not completed, but to date, they feel like it's okay if the nurse in the office or somebody that is trained asks them the questions. Some people have a fear that if it's at the MA level that they may not accurately reflect what I'm saying. But they feel like it should be the provider, the clinician, that gives them that advice and that intervention. Now, interestingly, when I've asked them about a social worker or behavioral health worker so far, and again, we're not finished the interviewing process, but I'm just sharing, the feedback has been very interesting to me because they're like, oh, I would be intimidated, or I would think I'm really bad if the social worker or the behavioral health person came and talked to me about my score on my screening test. So again, that may be a generational issue, an age issue. Time will tell as I continue to work. But I think it's very interesting and very important for us in a patient-centered world to listen to the consumer, because let me tell you, they have a lot to say about this. You know, we had very short questions, and I told everybody it's only going to take 20 minutes. They're still talking an hour later about this. So it's important to them. And I think some of the staff, felt like they were reluctant to address alcohol because they weren't so sure that they were on the right page themselves. And so how can I say something to this person if, maybe I fit into this group as well? And then I think the other thing, they don't want to label the patients. And I will tell you, some of the consumers were a little concerned about what was documented in that chart, and that's why they felt like the clinician was going to frame it correctly, whereas maybe somebody else in the office wouldn't. But they're concerned, and so the consumer shared that. And I think the other thing that's really important from the staff point of view is the need to share, to educate them again and some more. And oftentimes there's a lot of turnover in practices today, and so we think we've told them what is important about SBIRT and why we need to ask these questions and what the evidence is behind it. But I found that most of the practices really, the staff, physicians obviously had the evidence down, but most of the staff really couldn't give me the evidence behind why they were asking these questions, or what was the importance of it, what could it prevent, and where did we come up with the number of drinks, you know, that came out of this. So I think the continued need to educate. But I think one of the most important barriers was, which was often implicit in the interview, was the theoretical framework by which the staff view healthcare. So that lens. You know, we've typically been more focused in a medical model to treat what comes in the door and only what is presented to you. So this theoretical framework, or this concept of getting into prevention, is still new for a lot of practices, to really look at how this impacts of alcohol. Even we're not talking abuse yet, we're talking about the potential for abuse. And oh, by the way, too, one of the consumers I had was very interesting, because he shared with me that he was a recovered alcoholic. And he said, I started my journey with alcohol when I was still visiting the pediatrician. And he said, never, now he's late 20s, early 30s now, never has it come up, or did it come up. He said, I might be in a much better place today had it been introduced earlier. So like I say, the consumer is not opposed to this. They think it belongs. They want the doctor, they want the clinicians to understand the whole person. And a few people brought up, well, they wouldn't be truthful. One person told me the story of her friend who was not truthful. However, her not truthful landed her right in the category of misuse. So even though she supposedly was not truthful, she still showed up as having a problem. So they have a lot of good stories. And another one of the barriers that was somewhat implicit but still explicit was just the whole workflow dysfunction. How does this get administered? Who administers it? When does it administer it? Who is the one that's going to do the intervention? So the ability, there were a couple exceptions to this. There were like 2 practices that I interviewed that really had this workflow down fabulously. And they really knew exactly from the front desk person all the way back to the clinician. They were all on board, understand the importance, felt like it was a vital sign, just as critical as taking their blood pressure, and they even expressed it that way. The context of which they expressed the screening for all their prevention was really on top. So there were some exceptions to this. But I think that we need to help the practices with some workflow to understand how what best practices are. So reimbursement was not necessarily a barrier except when the patient was billed for it. Now that was a real barrier. So what I found is a lot of the practices were doing a lot more screening and brief intervention than they were actually billing for. But again, when I was trying to sort out with them what was getting paid and what was not getting paid and how was it paid, it was all, you know, it was all over the board. There are codes. CMS put out some codes, as most of you already know. One practice was billing 99420, which is health risk analysis assessment and being paid by all plans, to their knowledge. They were using that code when they were doing their assessments. They weren't sure what was subject to copay and deductibles. They weren't sure if it could be used with another E&M code. Some of them were feeling like it was getting denied if it was with another E&M code. And the contracting terms, they felt like influenced the billing, and paid maybe yes or maybe no using a 25 or 59 modifier. So there was not a lot of consensus or agreement or knowledge. Again, as we move into value-based contracts in the value-based world, that connection between the billing office, the contracting office, and the clinical staff is going to have to come together. Because if we're going to be paid based on outcomes and those particular quality measures or practice improvement measures that we're going to put into place, that understanding and awareness has to go from the front desk all the way back to the billing and the contracting. People have to communicate to the practices exactly what it is the outcome expectation is going to be. Now, getting to the insurance. So the goal here was to actually get down to the payment level, the claims payment. Because every one of the websites, and I took, and you can see in the report, I took all the payer plans that function in Colorado and attempted to reach to their claims payment department. That was a real trick. All of the websites spoke of SBIRT, so it was there. But it was very clear with every claims payment department that the beneficiary plan decides if the screening and brief intervention is covered, and the codes that are suggested to use for SBIRT are either covered or not covered based on the contract plan. Some of them went into under medical. Some of them fell under behavioral health, mental health conditions. But from the claims payment point of view, it was the codes based on what the contract said, period, end of story. They knew nothing about SBIRT. At that level, they knew nothing about SBIRT or ACA or essential benefits. It was, is it in my computer that says this code is to be paid or not paid? And that's it. Now, we know we've had some data shared this morning, and 90% of the older adults, 50 and over, use prescription over-the-counter medications and may interact adversely with alcohol. And statistically, alcohol addiction has remained primary substance abuse disorder for people age 50 and older, and this still holds true today. And while screening for unhealthy alcohol use with brief intervention ranks as one of the highest prevention priorities for adults, it is also shows one of the lowest delivery rates. And so it's very important for us to take a look again at how the practices are framing this. So in summary, what I discovered is that there's a lot more screening going on than what's ever being built. So if we're looking for the codes to try to determine how much screening and brief intervention or advice is actually carrying on, it's going to be very difficult to do that, because with the codes present a lot of different rules and regulations about who can administer it, when and under what circumstances, et cetera, et cetera. And it's actually, once you start diving into this, a little bit more complicated than just putting these codes on the claim form. Payers need to streamline and be consistent with how SBIRT is being administered. I would tell you, for some of the insurance plans, I took some of the very convoluted pieces of information that they had on their websites and said, this looks like a cut and paste of 3 or 4 different preventive services, because they don't even make sense. And so there needs to be some streamlining and consistency. They need to evaluate the level of staff that can provide intervention, because that inhibits, not every practice is going to have behavioral health or a licensed clinical social worker there to give the brief intervention that takes place. And for the insurance companies, it's all about the codes and the benefit plan. And the practices moving into value-based models of care need to be aware of their contracts. Interesting in interviewing the employers, not one of them so far knows anything about SBIRT. They couldn't even tell me, from small to medium, and still working on large employers, they couldn't even tell me if SBIRT was part of their benefit plan. They hadn't even heard about it or knew anything about it. All of them, with the education, we're going to go back and research it. All employers get their information from insurance brokers. So there's a level that we hadn't tackled yet. But this is going to be important to know what's on your contract. We already talked about that one. So what some of the recommendations were here at the practice level, again, it's for the practices to look at their theoretical framework. So one of the fun part about doing qualitative research is when we finish the questions and then you're just sitting there chatting and getting to what's really inside people, and you get to share bits and pieces of information and facts to them to see the changing, that occurs. And as I was sharing with practices all over the country for lots of reasons, not just SBIRT, although I have to tell you that I always include SBIRT now. No matter what I'm doing at any practice, even if it's macro or mixed, I'm always saying somehow I'm making sure SBIRT gets in there. So this is a good thing. But to take a look at how they look at patients, how they look at prevention in their practice, being able to switch that lens as we move into value-based payments. We have to switch that lens into a more population health and preventative framework. Then the staff training, development of positive cultural sensitive scripts. I think the consumers were, sensitive to how they were approached in the practice and what was said to them and how it was said. Revisiting again the healthcare reform, value-based care, and population health needs. Understanding their contracts. And then the interesting part too is that really for a lot of CMS and even for some Medicaid, using the audit tool or the MAST or some of the other ones are supposed to be in place after you have questioned the patient on whether they drink or not. I had one practice that she is collecting on every single Medicare patient, billing every single Medicare patient with a audit tool coding for reimbursement. Now, technically, Medicare says when you look through their convoluted little discussions there is that the master, the audit tool is supposed to be administered to those people that drink. And if the statistics show that 30% of our population don't even drink at all, Medicare is going to come back and say, why is 100% of all of your Medicare patients receiving the audit tool that I am getting billed for? So, again, you have to be careful because, believe it or not, there have been other places in the states across the country where they're fussy about that. So we need to help the practices with workflow mapping to include steps for how to administer the screens. What are the workflow best practices to actually get this implemented into the practice and how the intervention would take place? And then again, just addressing the practices through webinars and other means to help them, to educate them on this. So from the consumer level, and some of these we're already doing now, focus groups or surveys to gain their insight. And like I said, they have a lot to say about this. It's been very interesting. And I'm a big believer in practices developing patient councils. I think patient councils are wonderful ways of getting input from your consumers on what goes on in your practice and how you can assist your patients going through your practice. I think Press Ganey should be approached. They add questions on there about depression now. So you get your Press Ganey or your CGCAP surveys. They're asking questions. Let's have them start asking some questions on there. Is this happening at your practice level so that we can begin to measure it and, a little bit better? Practices, they can add it to their own surveys if they're doing their own surveys. Public service announcements by payers, including Medicare, to highlight the risk of alcohol and why asking these questions at your doctor's level is necessary. And I might add from both the consumer and the employer point of view that when I ask about asking the screening questions at the urgent care or the ED, a lot of them were like, well, I think maybe if it looks like it involves alcohol, you should ask the question, but not just every time a person comes into urgent care or ED. But after we finish the interview, and then I give them some statistics and some evidence as to why we would do that, and then I go back and I ask them, now, would you change your mind to this question? How do you answer this question? They all yes. Again, the education piece, giving them the education. We just cannot underestimate the power of the consumer in this, and the employers. All the employers were on board once they understood what an impact this could mean to them as well, too. So I think we need to do a better job. We're visiting the employers. We're looking at insurance companies and ways in which they are incentivizing. Of course, Kaiser is probably the one that stands out as the highest level of intervention because they started an SBIRT program in California that's pretty significant and some good outcome. And then there's 5 ways of dealing with insurance carriers when we're trying to get payer issues resolved with them. And that's keeping communication channels open at the state level, asking them to help us standardize some codes and tools and ways in which that the practices can be approached. But I think the other piece here that's really important from the payer point of view is implementation of market conduct exams. And the way that this works with the insurance company is when they distribute their product in the marketplace, how how widely is it distributed? So if SBIRT is an essential benefit and the parity exists, which we know it does in the state of Colorado, then going out and surveying and testing how well are the insurance companies here really distributing that information out in the marketplace. And then the network adequacy assessment is the ability of the health plan to provide enrollees with timely access to health care services included in their benefit. So when I asked the employers, is this including your benefit, and nobody knew, everybody was going to go back and look. Now, they had their awareness raised, and they were going to go back and ask, and they were also going to ask their broker, why did you not tell me about this? What's wrong here? And is it in the plan? So if the insurance companies are not, if this is part, which is supposed to be part of our essential benefit, if it is not being propagated to the brokers and then out to the employer plans, you know, we need to intervene and do something with that. And then collaboration. I agree totally with Stephen that all the state projects, SIM, TCPI, CPC Plus, everything, we need to integrate SBIRT and work on a collaborative effort. There's no room, as I shared with one practice recently with SIM, there's no room to say we don't have time for this, okay? It's important. It's important. So we just have to figure out how we're going to incorporate with this. So, again, the collective impact. Collective impact is what we're looking at as we move to value-based models of care and as we move into prevention and population health management. It is that collective impact from the ED, the urgent care, the physician's practice, the community, all of these services together that impact the outcome of this SBIRT. So, any questions? How are we doing on time? We're great? All right, so that was quick and more to come. It's been an exciting adventure for me as well, so I've been happy to share this with your group. Any questions or thoughts? Okay, good question. Both. So even if it went through as a preventative service that was not billed to the client at all, nothing was billed to them, they still did not believe to date that it should be billed to their insurance company. They don't believe, and like I said, I wish I had a video camera, because talk about collecting data. It was eyes up, this kind of thing, and hell knows, no questions like that should be billed to the insurance company, whether they pay for it or not, because they just didn't feel it was right. They felt it was part, so far. So we have to finish everybody and get to the younger generations and everybody to see what they feel. But the 50 and up so far, male and or female, have a very strong, one person said to me, well, we just had our physical not too long ago. I'm going to go back and I'm going to look that bill over and I'm going to call and find out. Because her physician here in Colorado asked the question. She said, I'm going to go find out if they billed my insurance company for that. They have a strong aversion to either way, whether they're billed for it, and like I said, the one consumer was, I'm not going to answer the questions if it's going to be billed to my insurance company. They just don't think it's right. It's part of, it's different than getting a mammogram. And you're billing that, it's a procedure. This is talking to my doctor and they're going to bill my insurance, then what's next?
My feeling is that by making a go-around and not including it in mainstream medicine of this is just business as usual. These are the questions we ask. And when I do your EKG, I don't say, I'm going to do an EKG. Now, do you want me to read it? Because I'm going to bill you for that. It's business as usual. This is part of health care, and it's very important. Now, I was a little intrigued by how against it consumers are. I was a little surprised, I have to tell you, because when we were billing in the last cycle, we billed thousands of patients, and we had very few complaints. We had one complaint that kind of set off a wild storm because she was a tobacco user. We put tobacco use disorder, and she said, no, I'm not going to be able to get life insurance and whatever. But out of all the patients that we screened and that showed up on their bill, we had very few complaints from patients about the fact that that was on their bill.
And they were Medicaid population?
Well, everything. I mean, we see Medicaid, Medicare, United Healthcare, auto insurance companies. We had little complaints about the fact that it was there. And, for us, it's just business as usual. The health educator, the nurses screen them up front. The health educators go and do more of a screen. And we do have to be sensitive to the people in recovery. I don't know what the right answer is, but I think by going around it and continuing to say we need different codes, we don't want insurance companies, we're not making it mainstream. This is about prevention. This is about asking patients every single time. Maybe the third time they'll be honest. So I have a gut reaction to the whole, we should, not bill them because then people will know that they actually have an extra drink. This isn't necessarily about addiction. This is about misuse. This is about at-risk drinking.
Which is
this is not really about addiction, although there are addicts in there.
And I think that's a good point. I will have to say that I think a lot of people are not even aware of what's on their bills half the time. And I think so. I think that's a piece of it. But I think also the fact that it's asking questions, and I think the context is important. And as we speak to some of the insurance companies as to how, like Kaiser, how they're actually incentivizing physicians and paying physicians to put something in place that should be mainstream. It's a question. I mean, I tell you, after 10 or so consumers, I was almost saying, well, yeah, that's right. I guess I don't really like them asking me questions, and now I'm going to wonder if every question I ask is going to be a charge with it. So I think there has to be some context to it for sure. Yes.
Thank you. My name is Megan Marks, and I work with Peer Assistance Services in the role of parity consultant with Colorado Coalition for Parity. And the issue has been raised there, and I think appropriately so, about championing the principle of parity in that it should be extended to screening and preventative care in addition to treatment. So it would make sense. I mean, we champion preventative care for primary medical concerns, and those issues are addressed at that level with providers. SBIRT certainly encourages that. Why are we not looking at this as an issue of parity?
Right.
So that individuals are treated fairly when an issue clearly a provider knows this is a risk factor for development of alcoholism or addiction. Let's address it now before we get there. And it's dealt with just like we deal with prevention of diabetes or prevention of other healthcare concerns.
Right. So. And so I'm in favor of just paying the physicians more, period, so they can include the preventive services that they need to include. That would be my fight with you.
I mean, it is paid by codes, and Alex can, talk about that for the Medicaid codes. But, as we're talking about that, maybe it's and we were interested in the whole thing of if you have a practice and you incorporate SBIRT, and you don't necessarily give it out at the patient-identified level. So maybe it's de-identified aggregate stuff. And you say, we performed this many brief screens, these many were positive, these are the things that we paid for in our practice. And then you get paid off of maybe some de-identified data. If that's the issue, the patients are afraid that they're going to be stigmatized, because we certainly don't want to stigmatize patients as far as future health care, being discriminated against. So, Lord, especially with the environment that we're maybe going into.
You don't know what the insurance companies do with information. So yeah.
But we have to still make it mainstream. If we continue to sneak around and pretend like this isn't an important issue, the idea that substance use does impact your health, then we're not going to budge.
Right, and I don't think there's a consumer that would disagree with that. Are we on our panel time now? I think we're still good? Okay, good. All right, still good. Go right ahead.
You also mentioned some of the providers saying they didn't want to ask the questions because of their own behavior. So, yeah, at Kaiser, one of the things that we did, you mentioned our alcohol drinking as a vital sign study. One of the things we did before that was actually go around and socialize the low-risk drinking limits like we do for portion control. I mean, we're talking about a public health. Are you wearing your bike helmet? And do you know what the low-risk drinking limits are? How many people in this room, we're sitting in an SBIRT room, can name the low-risk drinking limits? Most of us. But that's what I'm saying. We're in a room full of experts. So, I mean, that's exactly what we're talking about, is socializing it and talking about low risk, the word low risk, and talking about alcohol, those are new to all providers, behavioral health, primary care, medical assistants. We started talking about, how much alcohol is in a Chevy's margarita. Let's talk about that. And getting down to the nitty-gritty of really talking about it in a social way to get people feeling comfortable. And somebody asked earlier, if the providers aren't comfortable asking the questions, then obviously the patients aren't either.
Right.
Well, the medical assistants were the first place we started at Kaiser, because if the medical assistants aren't comfortable, then no one's going to be comfortable. So that was our number one priority. They ask all the vital sign questions, and they make people feel comfortable to put on a blood pressure cuff, so we should make them feel comfortable asking about alcohol.
Excellent. Yeah, Kaiser's done a good program. And I don't think there would be anybody that would debate that if they were sent for actual counseling or a problem was discovered, that they would disagree that there's not going to be a reimbursement for it, whether they could afford to pay for it or not, whether their insurance company pays for it or not, or how that all would work would be a question. But to ask the questions and then say, well, this drinking level that you're at right now may be impacting your diabetes, your weight, your hypertension, to ask those questions and then, put it on there at that level, I think is where people are having some trouble. Well,
no, Medicare does reimburse. So some of the insurance companies do reimburse a very small fee for just the screening.
Yep.
You get so many screenings per year, and I can't remember all. I think Medicare is like twice a year or whatever.
Some are 4.
So, and some of them pay for the screening if you are positive and then get on the brief intervention. So it's pretty complicated, but some do pay for screenings because, I say to patients that the insurance company helps make the codes because they think this is important. That's why they have codes for these specific questions, because they think it's really important that we're asking them and we're helping them with this.
But then again, that's setting the context, and I think that's critical, because I think people are open to that. I think we just need to have more conversations with our consumers. I think we definitely need to have more conversations.
So we're going to transition to a panel discussion, and pretty much carrying over a little bit from the discussion we just had with Pam, and also building upon our discussion earlier with Steve. Pardon me, folks, online, we're actually making some technology adjustments. Do they see all this, Gina? Okay, so you guys are right with us. So now you can see a bunch of pictures up there. And good golly, why is mine the largest? That's a problem. Let me just put that out there. And so I'm sitting now, falling down in a seat. Anyways, I wanted to kind of introduce the panel, and then I actually have 2 questions for the panel, and then we're going to open it up for all of you as well as those of you online who are communicating with Gina. But let me first kind of introduce the panel. You have met Steve Melek with Millliman. You have met Pamela Ballou-Nelson, who is with MGMA, Healthcare Consulting Group. Also want to introduce Dr. Carrie Broderick, who is a professor of emergency medicine with Denver Health Medical Center. And also want to introduce Tekla Brumber-Ross, who is a psychologist with Kaiser Permanente Care Management Institute and Northern California's Division of Research. Did I get that accurately? So we're thrilled to have Tekla, Carrie, Steve, and Pam as our panelists today. And so let me kind of just dive in with our first question for the panelists. And so pardon me with the way this is worded, and I'm happy to repeat. So the question is, how has what we have learned about SBIRT changed the way we care for patients and families? Would you like me to repeat that? Okay, you got it. So who would like to take a stab at this?
I was always the go-getter in school, right? I always wanted to go first. Well, I can say that before SBIRT started at Denver Health, which now we've been going since 2007, we never asked patients any meaningful questions about substance use. We asked the old questions, do you smoke? And if they said yes, we didn't say anything back. And then, do you drink socially? And what the hell does that mean? right? I mean, my doctor asked me that last week. Do you drink socially? I'm like, well, how am I supposed to answer that question? I got to give you a whole lecture here now on this whole thing before I even talk to you. But we never asked it. And not only that, because we have a program, I never saw the nurses talking to the patients in the room about substance use. And now they're sitting there putting the IV in and talking to them about it, and they're looking for health educators, and if they're not there, they're getting some flyers for them, and they're concerned that this is part of their health. This is really impacting their health more than most of the other stuff we see. So, of course, I have a very unique practice. I'm in the emergency department, and I have a very vulnerable, needy population. But this never happened 10 years ago. And now it's just business as usual down in that emergency department.
We have posters up at Kaiser in every medical office building in all of Colorado and all of Northern California that says, we ask everyone. And it has the low-risk drinking limits and the health effects of exceeding the low-risk drinking limits on your health. And then it has a picture of the Colorado SBIRT has the best images of the how much is a shot and how much is, how many ounces are in a bottle of wine and so on and so forth. And it's there so that members know that we care and that you can ask us questions and we can talk about this just like we can carbohydrates and protein and, other important vital signs in your health. So in Northern California, we call it alcohol as a vital sign. I know they do as well here at Kaiser, Colorado. And we really see asking about alcohol as another vital sign.
I think what we've learned about SBIRT and changed the way we've cared for patients is that, A, we've raised the awareness level and the education level to staff and hopefully to consumers as well to see that it's part of the whole person's health care. So I think in health care, we're looking at the whole person a lot more than we used to, and I would agree with Carrie that that's kind of the past. It's been very vague questions with actually no meaning or evidence behind them. So I think SBIRT has helped us raise that awareness and looking at the whole person and how important it is for health.
So I think of a comorbidity analysis we've done, and we're actually updating it with some more recent data, but we did it for the American Psychiatric Association a few years back. And if you get to the substance use treatment phase, and you look at the impact of comorbid substance use with any other chronic medical condition, diabetes, hypertension, et cetera, I mean, the costs skyrocket. A diabetic is going to cost, a regular diabetic, if I could use that term, is about $800 a month in healthcare costs. A substance-using diabetic is over $2,000, and that's not just for the substance use, that's the exacerbation it's having on their diabetes and emergency use and admissions, et cetera, et cetera. So SBIRT tries to head that off, right, before they ever get to the place where you've got a real difficult problem. So, and when I hear all the discussion about billing codes and paying for it and consumers worried about all this sort of stuff, and I understand and get that, but I'm going to repeat something I've been trying to champion within our SIM project, which is we got to change the way payment models work. And we're asking yet another thing of primary care practices to do. Emergency departments and others, anybody that's going to do SBIRT screening, prevention. And my pitch has been, let's figure out an appropriate risk-adjusted monthly payment per person, write them a check, give them that check every month and say, go do your thing. Get rid of the fee-for-service crap. Get rid of all the administrative burden and paperwork. Just say, here's your check. You're a nice practice. We're going to give you $500,000 every month. Take care of your patients the best you can, and we're going to actually give you some gain-sharing opportunities, too, because if you can reduce hospital costs for those patients, we'll give you a part of what we save. Stuff like that. I think we got to change the payment models. I hope I didn't piss anybody off by that comment, but I think that's what we have to do to make things work better. And I think there was a doctor in Minneapolis that wrote a book a while ago called Zero Trends. Healthcare cost trends have been going up and up and up, and they still do. We control them a little bit more every day, but his concept was real simple. here's how you get zero trends in healthcare costs. Keep the healthy people healthy and keep the sick people from getting sicker. So that's what we're trying to do here, I think, is one of those things, right? Keep the healthy people healthy and don't let them get sicker.
There's your population health management and your preventive, and I agree. Going into what is the one thing you'd recommend to elevate SBIRT as a standard clinical care? Change the payment. Don't get the payment structure and all the convoluted stuff that goes with it. Pay the physicians what they need to be paid to take care of the population and to work on preventive, because it's going to save us money in the long run on that pyramid. So.
Boy, Pam just jumped right into that second question. She could not wait. So I was actually going to say one thing about the first question, and that is I actually think SBIRT's been a game changer in a lot of different areas, one of which it actually places the concept of mental health and substance abuse as a preventative practice. SBIRT is much more than questions. And so actually, Pam, when you were talking about some of the attitudes and reflections, the thing I hinged on was questions were in billing statements. That, in my world, that should never be on any type of billing statement. The fact that we actually do a screening or an assessment, that should be a billable item, not questions. I do think because we're talking about questions, it's beginning to change the validity, the importance, or the integrity of mental health, substance abuse, or behavioral health. How are you define what we do? We've kind of, and Tekla, you may kind of connect with me on this, but we've been a bit of voodoo science if you go back to many, many decades. And I think now it's actually being able to give the concept and the profession of mental health and substance abuse real importance and validity, and the fact that we are part of the concepts that we struggle with, mental health and substance abuse, addictions, and psychiatric disorders. They're healthcare conditions just like anything else. So I think it's a game changer there. The second place, it's a game changer in our workforce, in how we train individuals, how we actually build the appropriate workforce with the appropriate knowledge to work in emergency medicine, to work in primary care, to work in hospitals, to work in advocacy organizations, criminal justice environments, and the like. And I think that's where we're beginning to see a shift in the system. So Pam already asked the question to herself, but I'm going to ask it to the entire panel. The second question I had was, what is the one thing you'd recommend to elevate SBIRT as a standard of clinical care?
Well, I do want to piggyback on exactly what you said. I do think SBIRT brings evidence-based questioning and brings behavioral health into the primary care arena in an evidence-based way that I think primary care providers and medical assistants and the whole medical arena is really grateful for. And it's not the, what do I do now that I've asked these questions, the Pandora's box, now what do I do next? We actually have evidence-based workflow of the best way to address unhealthy use and then refer to treatment for further assessment for those folks who do need that in the appropriate setting with chemical dependency providers who can do that. So I'm empowered to be a part of that evidence-based work, and I want to thank all of our researchers who've been doing that for decades. And you know, those NIAAA questions were researched word for specificity and sensitivity to detect misuse, and so a great shout out to all of our researchers. And repeat your question one more time as I was speaking.
So what is the one thing you'd recommend to elevate SBIRT as a standard of clinical care? Not just an evidence-based practice, but a standard of care.
We have all these champion teams at Kaiser. Every primary care physician is a champion of a particular initiative. So there's exercise as a vital sign team, and the alcohol is a vital sign team. And the exercise team recently came to us and said, the medical assistants are no longer comfortable asking patients about their exercise, but they're very comfortable in asking them about their alcohol use. How did that happen? Because of stigma. It was brought up earlier. When we ask about exercise, that means we're asking about weight, what did you eat, maybe family dynamics, how do you cook at home, what's your behavior in your car, so on and so forth. So we really have to, again, this is going back on something that Pamela said earlier, this is a public service announcement. You know, we have to say that this is a part of overall healthy lifestyle care. That means addressing alcohol in our culture and the power of Anheuser-Busch and Coors and Miller and, you know, the tobacco industry faced this 10 years ago, and now alcohol is facing it. So, yes.
Well, I think listening to we need metrics, right? Seeding metrics. So if we're going to actually make it standard setting, then every insurance company should ask for the metrics about how many of your lives covered did you ask screening questions about this, at least once a year. And of those that answered, what are the results can be de-identified, and of the results, how many did you refer to treatment? So, but you need metrics. So until the insurance, and back to the consumer almost, right? Even though the consumers didn't want to be billed for it and have it on their bill, but the consumers should feed into the insurance companies and say, do you cover it? And but I don't know that, the insurance brokers are going to give you the cheapest plan. But we have to have a metric. You have to report on it. I thought that's what actually the uniform data system was asking a few years ago, but I haven't heard much about it recently. They had the 1 year where they, had the SBIRT field for screening. The next year, well, how many, you had to have a denominator, but I haven't heard much about it in the last few years. So if they're going to pay for it, they should, start with Medicare and Medicaid and ask for some metrics and reporting how often you do it.
Well, I don't know what an actuary knows about clinical things, but what just struck me is I've, for different reasons, had my various visits to different doctors and things, and what are the vital signs? Height and weight, okay, blood work, CBCs, stuff like that, because I can't tell the doctor what my reds and whites and platelets and stuff are. I mean, my blood's got to tell them that, and all these vital signs, and strikes me that isn't SBIRT a vital sign that you can't get without asking. You got to do, got to stick me to get vital signs out of my blood work and cholesterol levels, and am I possibly diabetic or whatever else it is and stuff like that. But to me, it's just, maybe I'm just used to doctors at this point. It's another vital sign. It's how many glasses of wine do you have every week or whatever it is, and just like how much exercise you get in these days. Are you wearing a Fitbit or whatever it is that you're trying to do to stay healthy, sort of thing. So to the place where we can just get this is to be less stigmatized. And I get the stigma because I've been following healthcare cost utilization for mental health and substance use services for a lot of years. And good news is more people are using behavioral healthcare services thanks to the Parity Act and other things that reduce stigma. Of course, the payers are a little concerned about that, anything that's going to drive costs up. But I think if we can get payers to believe, and I think we've been trying to do this, that more prevention, more spent now will save money later. It's a good thing. You just got to take the leap, and I know you want to see data to prove that it's going to happen, but sometimes you just have to take a leap of faith that says more prevention good, future savings good, and it's good for everybody.
I know Pam already answered the question.
I already answered the question.
Thank you, panelists. I really want to kind of open it up to see what questions the audience and those online may have for the esteemed panelists we have here.
Well, I think U.S. Preventative Task Force list of prevention screening and seeing how high alcohol ranks in comparison to the other screenings we do at Kaiser routinely and annually is probably one of our most powerful tools to convince leadership. We, at least in Northern California, when we rolled out alcohol as a vital sign, we had incredible leadership from the physician-in-chief and then the head physician of all of Northern California, because we do see the positive impact. $1 spent, on screening, saving $4 on the back end. In our advised study, the alcohol drinking as a vital sign study, Dr. Jennifer Mertens was the principal investigator of that study. We looked at, going back to your question about, or your comment about the clinical health educator and then bringing somebody else in the room to talk about it. We looked at a non-physician provider doing the screening and the brief intervention compared to the physician provider, and what we found was that the MAs consistently did the best job at screening in the non-physician provider arm, but actually in the non-physician provider arm, we got a lot of work to do in terms of the integration of a clinical health educator or behavioral medicine consultant. Actually, the physicians did a more consistent job in terms of providing the brief intervention. And it goes back to a point that you kind of made about the health educator in terms of relating it to the presenting problem. So our workflow is that the physician states their concern, you're drinking beyond the low-risk limits. it's exacerbating your hypertension, your diabetes, your prediabetes, and I recommend you cut back. That's it. If they screen positive on the dependence risk questions, they go for further assessment in the appropriate place. Granted, again, I'm coming from a unique place where chemical dependency services in some of our regions is in-house. Not all, but some. So I think, going back to your initial question, how did we get leadership on board? I think U.S. Preventive Services Task Force and looking at dollars saved. We also know that patients who misuse alcohol use 50% more primary care visits per year. So there's just a whole host of evidence to support that it's not only good for our members and our patients, but it's good for us.
I think Steve's report is going to be powerful. I think it's for administration looking at that negative trend in healthcare costs for the primary care. Damn it, I wish the ER was in that trend too. We need some help, Steve. But I think that'll be pretty helpful. So it's another cost analysis study, which is as important as the evidence. We have to convince them it works.
So we got to ask a question. This is a few years back before Colorado SIM started, and there was just a whole concept of why don't we pay for an integrated care visit where on the same day you're seeing a medical clinician and a behavioral specialist too, and get, handoffs right there, pay for them both, an integrated care visit, both sides get paid for. And we were asked, so what would we have to save to pay for, the metric we just chose was 1,000. If for every 1,000 integrated care visits we paid for, how many inpatient admissions do we need to reduce to break even? The answer was 2. 2 admissions, 1,000 integrated care visits. Now this is going to cost less than an integrated care visit. Some hypotheticalizing, butcher up that word, it's probably 1. You'd probably provide 1,000 of SBIRT screens and save 1 admission and break even. So that's the trade-off we're talking about here.
The one alcohol withdrawal admission to the intensive care unit is about $20,000. We're not really talking about. We're trying to prevent all the other car accidents
and arrests and homelessness, and cost avoidance can actually start skyrocketing. Great question. Other questions?
How about, you've done a lot of work at Centura Health. I can't remember your name, Kim, but maybe you could answer the question too, because you're about as skilled as the rest of us there. So how would you, Eric's question was, how would you convince your, what tools would you use to convince your administration to do more of it? Is that kind of what I was getting a little bit? Yeah.
So I think part of it is that, sometimes when you're presenting like a pro forma to executives about this particular program, they're looking at, well, what is the reimbursement? And I always look at it from the opposite side of how it's changing for the positive health care so that we're not getting this turnstile of people into our facilities that we really don't need. So part of it is looking at that. Part of it is looking at the TQIP data, which is the Trauma Quality Improvement Program. So we really want to benchmark ourselves across the nation as to how many people we're really seeing. Improving our metrics from, we were interviewing 64% of our trauma patients, now we're at 96%. So really looking at the trauma population, but it's because we're concentrating on the trauma population because it's a regulatory requirement, we're missing all these other opportunities. Actually, my health educators say they miss that other population because now they're just seeing the trauma people. So trying to implement that, especially in terms of trying to decrease healthcare costs, which is the focus, I think of almost every healthcare organization in the nation, always looking at that from an FTE approach doesn't always work. So again, it goes to billing, our billing practices, how we're really cutting costs across the spectrum is a part of what I think would be
The other piece that actually I think about is Tanya had mentioned it earlier, is how you might be defining a health educator. What role, what skill sets, what background do they have? There are a variety of kind of training programs that are out there with individuals that may be coming from a peer recovery, personalized background or experience in that condition with advanced training, as well as those that may already have advanced training and have actually begin to kind of focus their professional career on the health educator role. So there might be a variety of different models of professionals. The other piece, there's been some evidence with regard to ongoing patient engagement, where individuals are actually following through in their treatment plans longer for a primary medical or physical health care condition, just because that they are remaining engaged with a care manager, an educator, a client care manager, so that you actually have long-term benefit beyond just the substance abuse issues.
Yeah, there's a lot of work that's been done with that in the HIV world, medication compliance and substance use, and if you can help their substance use, their medication compliance goes way up.
I just want to say something that I haven't heard too much of yet, which is we leveraged our Health Connect system, which is Epic, which we use at Kaiser, but hugely important piece of this implementation process. And you know, looking at something like, so it's, the alcohol question is part of our, what we call our MA rooming tool, and it's right alongside the tobacco screening and the blood pressure. And then the answers come into a documentation flow sheet so that the provider can see progress over time and see, are they actually cutting back on a future visit? And is that related to a lower BMI? Because it's right there. It's right next to it. Busy primary care providers don't have time to go digging through the social history section to calculate how many ounces of alcohol have been consumed over the past 10 years. So I just can't highlight enough how important that is in this evidence-based process.
And let me just say, I've spent an hour and a half with her husband because he was part of one of my interview, second phase of this. And I will tell you that they have a system down that's like nothing you have ever seen. And that does make a big difference. It makes a huge difference. And that's why I say helping best practices with workflow and how you actually implement this. But they have a system that really makes it easy for everybody. And I think, again, if we were to look at how can we standardize this, you know, coming up with a system approach that really works is important. But it's pretty impressive, very impressive. So that's another phase for you. And back in your back in the ACO world and your clinically integrated networks and your physician hospital organizations, and part of MIPS, one of the measures happens to be SBIRT. It's in there. It's one of the measures that can be utilized. So I think there's a lot of room for that.
Just an additional dream of mine back to your ongoing patient engagement piece that you mentioned before is our members and their own electronic, you know, health portal can graph their lab test results over time, like their liver enzymes and their cholesterol. In my dream world, you can graph your depression screening, your alcohol screening. So I'm hoping that at some point in my behavioral health career that happens.
There are apps that are doing that. There are apps. Engaging that or building that into Kaiser's electronic medical record platform, which I use on a regular basis, is something that might be, and I actually think is very foreseeable. If there are driverless cars and trucks, yes, absolutely. Gina. Well, that's an example of kind of how a community's culture changes, and that's Access Health Systems down in Durango, if you all are not aware. Other questions from the audience? What's that one thing that you're going to walk out saying, geez, I should have asked that question? Gina, do you have anything from those online, which we encourage? Hopefully you're not sleeping, had not enough caffeine. Any other questions? Panelists, I'd like to say thank you very much. Contributed an awful lot to today's discussion, and Steve and Pam specifically, kind of a carryover from your presentations. Carrie and Tekla, again, thank you very much for your contributions, and really made it a spot-on discussion and opportunity for all of us, so thank you. So we are winding down, and one little thing I'd like to really kind of give out a special shout out and thanks to Aaron Sharp and Gina Lasky for really helping kind of pull together the agenda, the speakers, the content, and the overall kind of program coordination. So thank you very much. And lastly, I definitely want to send out special gratitudes to my friend and colleague Elizabeth Pace with regard to her leadership here and kind of consummate friendship with me. I think you have been really a shining star, if not the North Star, concerning Colorado SBIRT, and thank you very much. And thank you for all the peer assistance and stuff. So with that, actually I think Elizabeth's going to say a couple of words to close our event today.
Thank you. So I see a lot of these...
Elizabeth, you must have a microphone. I believe so, yes. This is my last piece of power and control.
Give me that. I see that we have a lot of these cards here, our pocket cards. You please come by and get some on your way out. And there are also a couple of other things I'm not sure we mentioned. One of the projects that SBIRT did this past year was with Minds and Associates, the role of physicians in screening and alcohol use and aggregated survey review. So there are a number of other, I feel like Vanna up here, but you really grab some of these things. I think they're pretty fabulous. SBIRT Colorado, with the support of a lot of our subcontractors, with the support from OBH over the decade, where we have provided and implemented SBIRT across the state. This was really such a high point in a very small, to hear the I did not understand when I read it, of course, Steve, but it was very helpful to hear it stated. And I love that question. We really need to get this message out. Why aren't we doing this everywhere if the data are this good? So anyway, I think more to come on this. We're on the downside of our 10 years, but looking forward to the future and continuing training through certainly the end of February. And I know OBH has planned to continue SBI, and there's work going on with SIM, and all of that's really positive for our state. That is indeed a shining star, I think, in the country. I did want to take a couple of minutes to thank my team at Peer Assistance, certainly Amber Quartier and Aaron Sharp, and our help with from Gina Lasky, and thank you, Charlie Smith, as always. Also, right about now, we should, maybe it's over now, but Carolyn Swenson, who's been our trainer exemplar for so many years and worked in this state on SBI. Her dad passed away about a week and a half ago, so she and her family are in Indiana memorial service. So she is a rock, if there ever was one. So she is going to be around and continuing to take requests for training statewide. And we also have information, I'm pretty sure, on our website about the modules that are available through Cognito. So you can get CE if you care about that, but the training is really impressive, and so have a look-see at that. You know, a lot of you are in the treatment world or the major intervention world, especially if it's an emergency department. But my world and the world with our teams and the programs that we run at Peer Assistance Services really focus on prevention and early intervention. And we started, you know, to work with health professionals, nurses in particular, who themselves have substance use and related issues. And this is an equal opportunity health issue. None are exempt. And so I'm struck almost every week by what we might see in the I don't think this is working anymore, do you? Yes, it is. Thank you. And who has been arrested and will likely be prosecuted and likely go to jail. So I always ask this question. This is it's the last one in the last week and a half, which you've probably seen, is a 30-year-old woman from Aurora. I'm not exactly sure where she was working. But, you know, we're all healthcare professionals, doctors, nurses, social workers, et cetera, et cetera. Where was everybody? People do not wake up one morning and go to work and say, I think I'll divert some drugs, be found unconscious in the bathroom with a needle in my arm, lose my license, never go back to my profession, maybe lose my family. This is really serious stuff. Last fiscal year, we served almost 800 health professionals with our peer health programs, which are contracts with the Department of Regulatory Agencies. And that's a fairly small percentage of the professions that we help and assess and case manage. So it just seems to me that SBIRT is, and I thought this 10 years ago, it is the perfect vehicle to really change the way we think about alcohol use. Not abuse, not dependence, use. You have to, the doctors here, correct me if I'm wrong, but don't we have to create alcohol dehydrogenase in order to metabolize alcohol? You have to create, it is not normally running around in your stomach. Some of it is, but not to the levels when you consume alcohol. You rev up those little cells in the lining of your stomach that produce ADH. Well, alcohol is a known toxin, am I right? But many in this country, and probably in this room, choose to drink, quote, socially. You get asked that question. So we need to ratchet down things and talk about just alcohol use with women, with girls, with men, with boys, about how it affects your physiology day to day, how you get up the next morning. If you're performing brain surgery, how many pilots we don't let drink, right, supposedly before they, I think it's 48 hours or something like that, 12? Shouldn't be 12, it should be 48. Whatever it is, I think you get the point that I think there is so much more than we can do before we find someone under a bridge or find someone in a bathroom with a needle in their arm. Before we find this expose across the Denver Post with butterfly needles and stories of people that have died, miserable deaths, with minimal or no interventions when it could have made a difference. So that's our pitch here, and I think that it influences what we can do with people in the workplace, and we have done that with our OBH contracts and really trying to influence employers and how we think about this, the use of alcohol and other drugs, how we think about it differently. And so we just keep coming up, however, with new drugs so we don't have to talk about alcohol, right? So now it's marijuana. No, I know how to pronounce it. No, and so, well, we don't have to talk about it because it's legal now, right? So, yet we have found another way to divert. Maybe we'll just talk about illicit drugs. There's a lot that we can do, and SBIRT is a fabulous vehicle, and there's lots of information that we have available. So that's just my soapbox about how we need to move this upstream and prevent the kinds of disease and destruction of families that we see all the time. So I want to also thank and recognize Omni Research for all of their work all these years with SBIRT. and for your many contributions in support of all of our work, whether it's at OBH, our subcontractors, or our team at Peer Assistance. One more comment about language and the pejorative language we use around the use of alcohol and other drugs. That it would be very difficult if you're called an addict or a drunk or a junkie or all the very negative things that you can think about that are often used around alcohol, around people with substance use issues. If we can talk about this as a health issue over and over and over again, then maybe we can enable people to get help sooner. And finally, we had hoped that Mary Weber would be here from the College of Nursing at the University of Colorado to talk about the education that they have built into their undergraduate and graduate levels around alcohol use, so they get the ADH stuff right. But the point is that we don't educate just about screening. This starts with it's along the life continuum, birth to death, so that we teach nurses, physicians, pharmacists, dentists, social workers, whatever, psychologists, about alcohol use and how it acts on our chemistry, our physiology from the very beginning. And then people will then, or professionals, will be empowered and feel more comfort level changes when they're going to ask questions, when they screen. Do you use alcohol? And if so, how much? And so forth, and the rest of the questions that are available. So I think there's a lot out there. We have helped to support the College of Nursing with their efforts as well. And we being Erin and Amber in all likelihood, get out all of the handout. You have the handouts, but they will be emailed as well, along with the PowerPoints. And is there anything else that we'll be sending out? Right. Make sure people sign in so they know there's... Oh, please sign in so we have your email address, please. And thank you for spending your afternoon with us. It's very nice to see all of you and to hear the questions, and I think get some more ideas for the future. And thanks again to all of you for some of you coming at short notice. We appreciate that. And thanks again, Charlie.
That concludes the SBIRT Fall 2016 meeting, summit, forum. Have a wonderful rest of your week.